Hello Clinical Gemmers, and welcome to our March webinar, online CPD program by a clinician, that's me, Bronwyn Cooper, for clinicians. So that's you guys who at the moment are mostly podiatry audience. And each month we try to feature a clinical condition with an overview, or we may do a particular technique such as the Trigenics technique as practiced by our only Australian certified podiatrist in this technique, Mark Lynn, in the December edition of Clinical Gems. Now, we also like to try and put in a fairly challenging patient case. Tonight's patient has been my patient for 35 years, but he's already had his knees replaced, in fact 3 total knee replacements. So the video is to do with him because he presented with a new set of symptoms. He's had between 15 and 20 lower limb surgeries from the hip down, and has quite a distinct and unusual history. And increasingly we're seeing more and more of these complex patients within our practices, of people who have already been our patient in our practice for in this case 3.5 decades. As well, this is the example of a guy who had really significant and dreadful nocturnal cramps and still has some episodes from time to time. So I've talked previously, I think, about the example back 4 years ago, I think it was, where I was able to change that big time for him. So in the tips and tricks sort of segment that I try to cover each month, where you can take back some little practical thing you can use in your practice, we look at the physiology of nocturnal cramps, and in particular go a little bit more into how kinesio tape works for that. Okay, let's get stuck straight into knee osteoarthritis. So at a broad coverage of this, I've chosen to go to the Physiopedia site, like a Wikipedia but for health professionals, set up over 10 years ago in the UK as a not-for-profit to disseminate knowledge to, in particular, physios, although their website does say that about 20% of the users now are other allied health and medical people. So here are their smiling faces at the UK Physio Conference back in 2018. So you'll see their diagram, as in the definition here, is fairly rudimentary. 2 types generally of degenerative joint disease at the knee, or osteoarthritis of the knee. Now, the primary osteoarthritis we don't tend to see so much. That's where articular degeneration is caused without any apparent known cause. So it occurs, I should say, without apparent cause. The more common one is the secondary OA, where the degeneration of the articular cartilage comes about from abnormal force, such as in obesity, sadly on the increase, or abnormalities within the articular cartilage itself, such as in rheumatoid arthritis. And we know this is a progressive disease, leading sadly to increasing levels of disability. So I've used the American College of Rheumatology's guidelines to classify this, because you'll see later under treatment when I cover the update on medical laser or photobiomodulation for osteoarthritis of the knee, that meta-analysis of studies done on knee OA with PBM being used as treatment uses this definition as the criteria for including the studies into their as meeting the criteria to meet their guidelines. So first up, if you just use the history and physical exam, you'll see that the American College of Rheumatologists suggests that there must be pain in the knee and one of the following. So over 50 years of age, less than 30 minutes of morning stiffness, crepitus on active motion, bony tenderness or bony enlargement, and no palpable warmth of the synovium. So just the physical exam consisting of the history of pain in the knee and then one of those. So if you then use their guidelines where they add in radiographic or X-ray or imaging findings as well, you'll see that the criteria is pain in the knee and at least one of the following, so over 50 years of age, less than 30 minutes of morning stiffness, crepitus on active motion and osteophytes, so that this would be showing up on X-ray. So you're correlating it with X-ray. And if you look at the third level, where they then include laboratory findings on bloods and so on, you'll see that this is harder for me to read, the sediment with the bloods, you're excluding things that don't show up the inflammatory markers in the bloods and so on. So the sedimentation rate being less than 40 millimoles per hour, rheumatoid factor being, I think it's less than 1 in 40. Yes, less than 1 in 40, and synovial fluid, signs of osteoarthritis. So that last one would be a positive for that. Okay, so already in our practices we see people that are telling us about these symptoms. So the knee pain, gradual in onset, usually worse with activity, stiffness and swelling, and pain after prolonged sitting or resting. So if we then look at the epidemiology of this condition, it's actually the most common disease of joints, all joints of the body worldwide, no surprise. 13% of women and 10% of men over 60 are affected, according to Physipedia. Over 70, however, the prevalence goes up to over 40% of this population, and of course it increases with obesity. Now, if we look at the etiology, without any known reason, as we talked about earlier, the primary one, they're really not sure. They're querying, is it due to age as well as wear and tear? Question mark, just don't know. I have a friend who in their family, all of them end up having to have their knees replaced at mid-50s, and it's a very positive familial factor in their family. Secondary, due to known reasons such as, now, obesity. Now, hypermobility of joints, I would include in there, I'm sure it's meant to be knee hypermobility, but as we know, people can have a positive Baton score and have multiple joints that are hypermobile. And it's possible to have hypermobility in segments of the foot without elsewhere, providing a really unstable base of support on which the knee functions, of course. So the malpositioning we know about with your knock knee, your genu valgum and genu verum and so on. Now, a history of previous injury, obviously, the family history, which is one of the ones I alluded to before. And look, the metabolic disease such as rickets, well, that's certainly not terribly relevant in our Western society nowadays. Pathological process. So we're talking here about even the chemical equilibrium to do with cartilage maintenance. We're talking also where you get the collagen being disorganized, loss of cartilage elasticity, and ultimately the cracking of cartilage. And we're talking about the strong articular cartilage that lines the distal end of the femur and the top of the tibia and the back of the patella here, not the sort of cushioning type cartilage, which is your meniscus. So we get cracking and erosion of that area. And I'll just check, Caesar, if you're still there, can you just let me know if you can hear me okay now? Hopefully you can. I don't have my support person here with me tonight, and I think I've fixed that particular problem. I certainly hope so. So the cartilage wears away and the bone eventually becomes affected and starts to erode, and we then get bone spurring developing, as you know, which is certainly not a happy scenario once that happens. Now, what we've just talked about, there's a fairly graphic demonstration of it just there, and you'll see a nice fibro-articular cartilage here, and you'll see the erosion of the area and the usual terrible mess that we see with this condition. So 5 particular categories with osteoarthritis, 0 being a normal knee. I have been, for example, beginning to question whether I might be developing arthritis in my slightly unstable knee myself with my torn meniscus, and it's a significant meniscal tear.
and when I look at this, I think I'd probably call it into a grade 2, but I don't get stiffness, I get a little bit of instability. So it's not a classic grade 2 at all. So grade 3, moderate osteoarthritis, frequent pain when moving, joint stiffness, obvious cartilage damage, etc., and then the narrowing of the joint spaces. So the severe osteoarthritis is a real problem. As we know, cartilage is totally gone by that point, and high pain levels with movement. Now, this is a thing that most health professionals can certainly help guide their patients more with. And I have to say, at the SportsMed conference in the last face-to-face SportsMed Australia National Conference was in Twin Waters up at the Sunshine Coast in when was it? In 2019 now. Sorry, COVID does that to you. And there was a very big segment on osteoarthritis, and I was mentioning that earlier, but I don't think you quite heard that. So we often see patients with these sort of x-rays where there's a very significant narrowing of the joint space, as you can see here, which is a real problem. And certainly on the other view, not so bad. So diagnostic tests we're pretty familiar with, and we've just run through some of that when we talked about the symptoms and the presentation. Blood tests are usually not necessary with osteoarthritis, as you know. The arthrocentesis is you're drawing up of the synovial fluid to have that analysed at the lab. Now, that in itself can lead to certain problems because you're doing an invasive test, as you know, and introducing a needle into the joint space, etc. Now, arthroscopy, I wouldn't categorise myself so much as a diagnostic test. Arthroscopy seems to have, dare we say it, fallen out of favour somewhat. I think it was probably because it was overutilised years ago, and the concept of putting the scope in and introducing it into the joint space, it allowed the surgeon also, as you know, to trim up loose bits of cartilage and various other small defects at the time. But largely this hasn't led to the improvement that was thought was going to happen to a lot of arthritic knees and knee issues generally. So the classics still are your MRI and other imaging, x-rays first and then MRI. Often these people don't need an MRI if it's as bad as some of the earlier examples we've seen. Now, in the past, we've all thought that surgical options for the knee were far better than what is increasingly showing up now. And I don't have the figures to show you, and you'll see some of the Royal College of GPs data coming up to do with injections, where there's not necessarily data for a lot of things. And what's increasingly happening now is that patients are being, as I mentioned to you earlier, asked to lose weight before surgery when they're obese. So body mass index greater than 30, I think, is the current definition still. They're also being asked to do exercise programs. And look, frankly, anyone who's using medical laser in their practice would know too that prehab in the form of that, as well as an exercise program even before they go to surgery, would be a far better option. So the conservative measures take on much more importance than I think they used to once upon a time. There's still not good evidence about medications slowing inflammatory conditions. It can do with things like rheumatoid arthritis, as we know, but for general knee OA, there's not any particular disease-modifying agents that can be used. Now, some people still like to use their fish oil and their shark cartilage and various things that they believe work for them, and yet you'll hear some of the boffins indicate that those do not have a proven record. So patient education really in conjunction with therapies first up, and this would all make sense. But the role of patient education was emphasised once again at the very big streams of knee osteoarthritis and arthritis generally at that SportsMed conference. And there was a psychology presentation in particular that showed they checked on patients who'd been told by their GP that they had significant knee osteoarthritis. Now, what most of them heard is, therefore, nothing can be done other than a knee replacement, and that's it. Nothing can be done. That's what they thought the doctor was saying. It wasn't what the doctor was saying. So they've discovered that the way in which even the GP couches the diagnosis to the patient is critically important, and the physiotherapy program, and programs plural. Now, the GLAD, if some of you may not be aware of this, and I certainly wasn't until I was at that SportMed conference 18 months ago. So the Good Life Arthritis Denmark is the acronym that that's for, and you'll see the specifics of that program in a minute. We've talked about the weight loss being really important. Knee bracing. Now, taping has always played a part, and originally it was the McConnell knee taping technique to stabilise the drift of the patella, for example, and not just for knee osteoarthritis, it was for maltracking patella and other things. So our physio colleague here in Sydney, Jenny McConnell, who was well known for that, I think it was developed in the 80s. Knee bracing, first line of call with GPs often was the anti-inflammatories in the early days, but that's changed a lot now after patients were developing gastrointestinal symptoms from that. So I went to one of my suppliers' handbook, in fact, GJO catalogue, and the majority of braces that were in there for the knee are not for osteoarthritis. So you've got to recognise that not all braces are equal. There are many, many good braces out there. Some of them for unilateral compartment osteoarthritis, and some in particular for unstable meniscus and ACL and so on injuries. So just mentioning that. Also, there's a plethora of online products that are available, as you would know. So the patella strap is a classic one. And look, sometimes just changing the force through the knee can make a difference to patients, even though this is not a particularly designed one just for knee osteoarthritis. You'll notice, by the way, when we get towards the end of this little bit of the presentation, there's not a significant, there's no mention of orthoses, foot gear in the form of muscle activating and offloading the knee footwear or shoes, and medical laser, shockwave and various other things in Physipedia on knee osteoarthritis. But look, this is typical of what you'll find everywhere, that you will not find for any clinical condition the whole range of treatment modalities being talked about. And I really want to alert you to that tonight so that you can always be open-minded and still go looking for other information. Because in these days of evidence-based medicine, you're finding that not all the evidence is out there yet. And as Professor Karen Khan said at one of our podiatric conferences some years ago, so the eminent sports physician from Melbourne, who's now over at Canada and I think University of British Columbia, he gave a great presentation on what to do when the evidence is lacking, which was basically to use your common sense and your best clinical judgment and apply those principles, which is pretty much how most of us have practiced now for some time anyway. So these particular researchers in Denmark, in conjunction with Arthritis Denmark, put out this program, and as you can see, quite significant when it leads to a reduction in pain by 36%, less consumption of analgesics, even perceived need of surgery, and improvement in joint confidence or the ability to feel strong when on the leg and functioning. So they did a 12-month follow-up and do that in these programs, and that's why they know that this has had improvement on the at the 12-month time frame. So what we're talking about is a very specific 8-week exercise program. There's initial assessment. I think a lot of you know about the chair stand test and the 40-metre walk test, etc. You can see we've discussed the importance of education, so there's quite a bit in the program to do with that, to get the patients on the same page as the therapist to understand the importance of the treatment. And it's not just called an exercise session. The 12 sessions are called neuromuscular because there's a big change and emphasis to, it's about proprioception as well as muscle strength. And then the follow-up assessment where it's retested to gauge the results. So we're talking about here the overview where they're assessed by the physio. You'll see this where you can read it better when it's a bit hard to see on the screen at the moment in this size. but the very specific patient education. Then they embark on the 6 weeks of the class-based exercise program, and then we have the follow-up. So if we break that down, you'll see there's the assessment, as I said, by the therapist, and then when the eligible participants are able to be taken into the program, they establish their baseline so they can measure it at the end to do with pain and range of movement and lots of different things. So as you can see, quite a good education program. And look, these are being rolled out all throughout Australia. So if you're not already aware of this, I think I saw on my colleague, was it our colleague Mia Lowe's clinic out of Adelaide, Saltfleet Clinic. I think I saw they offered the GLAD program, or if it wasn't them, it was another practice, perhaps in Victoria, where they offer other allied health, and they are doing the GLAD program. It's generally done through physiotherapy, obviously. So the very specific 6 weeks of exercise is the neuromuscular exercise we're talking about with the NMEX, and 3-month follow-up and 12-month follow-up. So what do the exercises look like? You'll see the Swiss ball. Oh, and this can also be used for osteoarthritis of the hip, which I haven't mentioned, but I've seen that when I've looked at the research on this. So you've got your particular lunges, your step-up exercises, and your chair stands and squats. So in the interest of time, we'll just keep moving on that, but I notice La Trobe University, big sports med clinics, they're all offering this very valuable and worthwhile program. And, you know, I'm here in Drummoyne in Sydney, Huddersfield Private Hospital, which is it's about 2 suburbs away. They're offering this as a program. The APA say that the cost generally is going to be in the region of about $500 to $700, but it can be done a bit cheaper than that, depending on whether it's a public program. So, if conservative management fails, and really I think we're going to get to the point where the GLAD program will be put into this conservative area, therapeutic injections have been classified within this site that I've looked at for this presentation tonight under the surgical inventions. And I suppose in the sense that you're putting a needle into the joint, then yes, I'd certainly call it an intervention. Whether it's surgery, that remains to be seen. Look, the high tibial osteotomies, I don't hear of many being done, and my own patient is in the presentation, had one of those, as had my own father, and all of them were not a success, so I guess that means they're a failure. Arthroplasties, arthroscopes, and then your total knee replacement, so we're all familiar with those. So just a bit of an overview on injections, in particular because we don't come across many steroid injections being done within the knee, but I did have a patient last week, a new patient who's a parking patrol officer. He had a steroid injection into his knee with success. No, sorry, that was a blood platelet. He has had steroid injections somewhere else in the past. Maybe that was his hip. So we know that it's a synthetic version of human cortisol. It's anti-inflammatory. It's only effective for pain reduction, but doesn't always work. Certainly wouldn't expect the results to last more than 3 months in most instances of the injections being given, not just even NEOA. And you're looking at this particular study, which is a bit historic now, effective reduction in the pain at 1 week compared to the placebo, but no pain relief over a longer period. Now the hyalurononic, I should have learned how to pronounce that. Some of you will know how to pronounce that. Acid injection is really to supplement your synovial joint fluid, because it's a component of our synovial joint fluid. Now, I actually don't know much about this. I know more about blood platelet and cortisone injections, this one. The theory is greater shock absorption and lubrication. But, you know, introducing a needle into the joint is not without its own risks. Now, I did attend an update on osteoarthritis in general at the Garvan Institute at St Vincent's Hospital 2 years ago. And they said then on NEOA that PRP injections, platelet-rich plasma injections, were very effective at relieving the symptoms, but the evidence wasn't in then. Now, I think the evidence might be in this site that I've looked at just might not be updated. And it's been done for longer than I realised, since the 1970s. And as you know, the safe thing is it's the patient's own blood where the platelet-rich component's been injected into the relevant site. Now, it does seem to be more successful at the knee than a lot of other joints. I do know someone who's had it done successfully at the thumb. When I first had patients of my own having this done, they reported their knee pain symptoms went down from an 8 to about a 3. And they think it buys the patient more time before they might need their total joint replacement. Incidentally, half joint replacements, they were popular for a while for some patients, don't seem to be around, and I think they might have fallen out of favour. So it's thought that the growth factors within the PRPs aid the body's natural healing process. So it'll be interesting to see over time how that pans out. So you can see the actual technique there with that being done into the shoulder, of course, not the knee. Now, the Royal Australian College of GPs have some comments about a lot of things, and their comments are not always up to date. I know that, for example, they rejected information about medical laser for treatment of osteoarthritis of the knee, despite the very compelling study that I'll be alluding to shortly. So even here, you know, as they say, because the evidence is low for cortisone injections, it's not something that they highly recommend. So the viscose supplementation we've talked about, same thing, very low evidence. If we then move on to the blood platelet injections, once again, they're unable to say a lot. And I think this was obtained off their website just in the last few days. So their recommendation is fairly neutral on that, based purely on evidence. But if you know someone has had this done and their pain's gone, as I said, down from an 8 to a 2, you'll know they're very keen on it. Now, as I said, Physiopedia doesn't mention, like most other sites, whether it's the College of GPs or this basic site for health professionals, in particular physios, it doesn't mention the role of orthotics, footgear, medical laser, shockwave, stem cells, etc. Now, let's just go into a discredited concept where ASIC came up with a shoe they called the Melbourne OA because they wanted to put some features in there to apply some valgus forces, I believe it was. I think it was around, might not have been as early as 2007, but I've got one of the old catalogues from ASIC. I just haven't been able to cite it in the last few days to check on the time frame. And it was available only on medical prescription. So some of you may never have heard of this particular shoe. It was in selected shoe stores as almost like a pharmacy shoe item. It didn't work out, despite the fact that the study at Melbourne University on which the concept was based showed that applying those sort of forces would help offload arthritic knees, was my understanding of that particular study. Now, the footgear that has a positive effect on the knee generally reduces force by anything up to 19% and increases muscle activation. So the original ones that started this were MBT of Switzerland. The Kai boot I've just thrown in as an example, and there's your air cushion type effect, but it's also a rocker. So clinically proven. Joya also by the inventor of MBT. FitFlop, Hocker, there's a whole range of shoes that fall into this category, but the ones with unstable rubber soles, such as the Kai boot, increase muscle activation around the knee and other weight-bearing linkages. And I've talked about that fairly extensively and shown various slides in other presentations, so I'm not going into it in detail tonight. Now, the efficacy of laser therapy, medical laser, what used to be known as low-level light therapy or laser therapy, but increasingly is changed now to the term photobiomodulation. And I've mentioned in a previous presentation that this is the definitive article published in the British Medical Journal in November 2019, because it was a meta-analysis, and here's a few of the findings out of that study, of the randomised placebo-controlled trials where laser was used to treat pain and disability of knee osteoarthritis, because we know that we're not able to cure the arthritis with these sort of treatments at the moment. What your aim is really is to reduce pain and inflammation, increase activity, etc., and reduce disability for the patient. So I've alluded to the American College of Rheumatology guidelines because this meta-analysis excluded any studies that didn't use that definition. They also only included the ones that had laser therapy delivered according to the WALT, that's the World Association of Laser Therapy Guidelines. And what that showed, that if the strength of the wavelength of the light, infrared wavelength, was in the 780 to 860 nanometers, then you needed 4 joules of energy or greater than 4 joules of energy. So that's your lower level lasers going up to about a 500 milliwatt. Generally, a high-powered laser is referred to as the ones that are a full 7 watts and higher. My own MLS behind me is 25 watts. So if you then move to the 904 wavelength nanometer, which is your pain relieving wavelength in particular, you were down to using about a joule of energy to deliver the treatment, as worked out over many years, decades, by the World Association of Laser Therapy. So it meant that there were 22 papers or trials that could then be analysed for the sake of coming up with some sort of conclusion about whether medical laser is effective. Now you'll see here that the results were that yes, it does significantly reduce the pain level and the disability level. And you'll see it was compared to the placebo at the end of treatment. And it was also, I believe, 1 to 12 weeks post-treatment. Now, I think this wasn't followed up beyond 3 months. I think most of these studies ended there. I'm not 100% clear on that. Okay, so I haven't included a case tonight of knee osteoarthritis because, as I said earlier, I've covered quite a few in previous presentations. What I am doing is I'm presenting an unusual case in the sense that we all have patients that have been with us for a long time. If we've been in practice for some time, and if we're lucky and they're lucky, and we have a great relationship with each other, they continue to stay under our care as their body changes. And of course, medical practice and podiatric and allied health practice changes. So what do you do if your 72-year-old retired male patient, who I've been looking after for 35 years, suddenly limps in last Friday with severe onset of severe pain in the right foot, presenting in the rear foot, lateral side behind the malleolus, no pain on palpation anywhere. He thought it was a bit on the medial side of the arch, not in the plantar arch area. Came in using a walking stick for balance, etc. Now, this man's had 4 joint replacements across 3 joints, and he has had bilateral triple arthrodesis of the feet, and his hip replacement had to be removed when he got a coral cut infection that migrated to his hip, and they had to take the prosthesis out, and he spent 6 months in a private hospital until they managed to get rid of all of that. And I mean the infection, and then they had to put a new prosthesis in. So I don't always see Pete's legs. One of the things that worried me with this sudden onset of pain is what's happening here. You'll see that his right calf is bigger, but I think that's because of his affected motor function. You'll see this looks a bit more swollen than the other foot. Both feet are fused into a pronated position. Now, you'll see from his gait, and if you watch this here, which goes for a bit over 30 seconds, he's hanging onto the wall for stability and balance, and you can see his gait normally is a very swaggering lateral sort of sway gait, and he's walking extremely badly. I was quite intrigued to find when I reviewed his notes that when he first presented to me in 1986, he'd done a 42k walk. Now, he would even remember what a 42k walk looked like now, and this was prior to any of these surgeries, by the way, none of them back in that era. In 1986, he would have been not quite 30, right? So I did a bit of a summary because he's quite an extensive file, and you'll actually see all of these surgeries on the right knee, the right hip, because it had the revision. He was hospitalised in the July 2010, January 2011. They finally could replace or put a prosthesis in there again. His arthrodeses, a couple of previous ankle surgeries for soft tissue injuries, What is missing is his left total knee replacement, which I think was about 2004. So, you know, we're going to see more of these patients. He's a bit unusual, I have to say, and he's also a man who's very unlucky. So, look, what I did, I explained it on the video, but I had a little technical glitch earlier and I started just slightly late. So I decided to laser Pete anyway, and I'm carrying that out while I'm checking out various things because I've got my hands-free laser. So if you like to just listen to the video, you'll get some of this story.
Okay, so I'm here today with one of my favourite patients, Pete, who it turns out I've had a professional relationship and personal friendship with for 35 years. So Pete's file goes back to the old days of paper records and copious quantities of athletic scripts and all sorts of things. Now, you've seen on the earlier video that he's lived in today in significant pain in his right foot. There is nothing painful on palpation, particularly on the general areas, but there is underneath the foot that I don't think that's, okay.
On the top part of this, where your right index, your first index finger is, there's a bit of pain.
There.
Not there, but further down.
Down towards the toes.
So go back up a bit.
It often moves. It could have been the first time even. Right?
Okay.
Okay.
It's okay.
Right. Now, what's happening is the foot is probably a bit more enlarged. He's had a triple arthrodesis, so let's just go broad spectrum after I explain that he is really here because he woke up. I haven't seen him for 12 months, but he woke up about 2 days ago and it was really painful to wait there. And you've seen in the video that I filmed earlier, he had to touch the wall for turning around and for a bit of unsteadiness. He's had multiple surgeries. He's had 2 triple arthrodeses, and I think one was actually back, so one on each foot, back in about 90 something or other. It was a fair while back.
One was 2008, that one was 2005, I think it was.
Yes, he knows his history fairly well. I think that's right, actually, because I know who the surgeon was. I see him at least once a year annually. I'm looking to see, because he's got a much bigger calf on this side of the nest, but I think it's all as a result of affected motor function. There's nothing warm or hot in the foot. It feels the same as the other. It's a generalised thickening. I think it probably is a bit more swollen than normal, but it's not pitting edema particularly. A little bit of fluid around here. I'm just using a biostim setting for pain relief because I want to offer Peter something, and he comes a long way across half a city to get here. I've checked to see, no change in temperature. I've checked to see whether there might be possibly a deep DVT there, but as I said, I think it's really the different motor function and the smaller calf as a result of that. So I'm running a hands-free multiple diode head laser on here with a pain relief setting to see if that helps. And I'm going to send him back to get an X-ray because he hasn't had one for quite a while. And that's like 15 years at least since you've had one of those triple arthrodesis. I think this one was the first one done. I could be wrong. Peter's had 3 knee replacements. He's only got 2 legs. That's right, is it? Correct. He also had the misfortune, he has a lot of bad luck, this guy, he had the misfortune to get a golden staph infection where he had a total hip replacement, years later, and you lay on your back in a private hospital in Sydney without being able to move for some months, with the hip space until the osteomyelitis was settled.
I know he died twice. Because it got really bad.
It did, yeah, it was very serious.
They call it a real, the Monday special doctor.
Yes, because it's such a virulent infection, and all he'd done is gone on a nice tropical holiday Cairns or Port Douglas, had a cold cut in your elbow. I remember you telling me.
Yeah,
migrated, as they say these things do, to the slippery surface of the prosthesis.
I didn't treat it straight away.
Yeah, that's right. And so he's not like that anymore. Naturally, he's not for that. His bedside is always listen to his body and say his body's got a lot of
things it wants to say to you. Now, Peter's sitting in a position where he's very externally rotated, the hip and abducted. It could just be that this is a culmination now of years of you having to walk a bit like Charlie Chaplin and rock from side to side. There are some painful spots here, and it's not just a straight witness test. So while I'm doing a general biostimulating setting on the hands-free laser, I'm also just treating. It's not the trigger point setting that I'm doing it for a little bit longer. It's to do with the number of joules of energy that are being delivered, and I actually forgot what it is. I have to look at the screen, but it's a biostimulation setting of 1500 hertz at 100% intensity that we're doing in various segments. So it's about 8 minutes, but I've done the rear foot and ankle and subtalar joint first, and now I've done the more lateral side and the top of the foot. Interestingly, while this is running, Peter's a patient who had shocking, is that ticklish or sore? Yeah, ticklish, not sore. No, okay. Peter's a patient who came in one time about, I think, 4 or 5 years ago with the absolutely shocking. And it turned out he wasn't getting sleep at night. He was waking up and having to wait there every night because of nocturnal cramps. It was so bad, despite you taking magnesium and other things. And I kinesio take the affected muscle groups between your shins.
Yeah, and the kinesio take work, yes.
Yeah, because when I rang you the next day to check on you, I was hoping you would have had a 20% improvement and the intensity and perhaps 20% fewer cramps. And as soon as you knew it was me on the phone, you said, "Oh, Bronwyn, you've never guess what." It was great built in your voice. So before I asked the question as to how you got on, you said to me, "Guess what? I slept like a baby." And interestingly, I had an 86-year-old lady in who thought her cramps were probably related to chemo-induced neuropathy. And she was in 2 weeks ago. In fact, it's 2 weeks today, I think, because it was also a Friday. And what happened was when I rang her on Monday, she rang me on Monday, she said the same thing. And I saw her 10 days later and she said she had 95% improvement. Now, that was not using kinesio tape. I think when you were in, we did that. It was before I had my laser. Now, in the interest of time, I'll stop that because I just sort of winged this as I filmed this the other day, and you've heard some of this story already. Okay, so as I was having to think on my feet about Peter, I followed up with him, by the way, but I did kinesio tape his foot at the end of this treatment. I also put him into a new stable rocker shoe because he had on a pair of the unstable Joya shoes that were totally trash, because when he walks, as you would have noticed, he's really stuck pretty much in almost a dorsiflex position as well as totally pronated. Now, on further questioning, he indicated that he'd been to the physio, that he's looked after him for about 10 years less than I have, so gone to Robin for a really, really long time. One of our best physios here in Sydney, Robin Gadge, who was my associate physio in my rooms when I was in the city. So we worked in well together, and Robin has been treating his hip and back. Now, I did say to Pete towards the end of this recording that I felt this may well be coming from his hip or his back, and could well be a neural problem up there. His foot's certainly fixed in a very externally rotated position because of the hip angle. But I was hoping I could at least give him some pain relief. Now, he told me when I messaged him on Sunday, 2 days later, that he was in a lot of pain driving home because the right foot was on the accelerator. And I've had this recently from another patient who has had a triple arthrodesis where I think there might be a problem with the screw. So at the moment, we relieve her pain with a laser, and she has been reviewed by the surgeon, but I think she's going to have to go back again. And she's much worse with driving with a foot, but it's the other foot for her, when the foot's resting on the, that little rest pedal. It's not really a pedal on the left-hand side of the brake pedal in your automatic car. So when I looked at Pete's notes, I put my head together with the physio. We spoke on Monday. I've advised Pete that I think this is the problem. Now, I've also hired him out a home use laser. And so in the interests of just probably showing that, I'll take this on and I'll see if we get to the point where There it is. So that's the class 2, as distinct from the class 4 I'm using, treating him there. A home use laser, which can also be used in clinics. It's very effective, particularly if you can. Yeah, that's just taken that back to the beginning. So I'll just see if I can move that on. But that's your handy pulse laser. So I've hired that out to him. Now, I've spoken to him also on Monday, and he told me, though, he did have some relief with his foot. He also told me that, sorry, dog's in the background, with his foot symptoms. He also told me he didn't want to take the kinesio tape off. Light won't penetrate through the tape, but I then convinced him to laser the adjacent areas where the tape wasn't covering. And remember, this is the man that his nocturnal cramps were totally alleviated with kinesio tape when I taped, about 4 years ago, the muscle groups that were waking him up to 5 times a night, every night. And he had his first uninterrupted night's sleep the very night after I taped him. And I was surprised to find I've been taping him at various times since way back in 2011. I just couldn't remember how long ago I'd been using kinesio tape for. So the moral of the story here is our treatment modalities need to change and are changing as our patients themselves with their problems and their age is changing. He's got 2 artificial knees, so he's not an example of knee osteoarthritis, but certainly I think his knee replacements may have been done earlier than perhaps they should have, because we didn't have these better approaches, conservative approaches to get people into a better state pre-surgery, such as we have now. Now, if I go forward, and just the quick summary for Pete. 1986, he came in after doing a 42k walk with blisters, calluses, and what he called split toe webbing, so the behind the toes individually. So he's been a patient in all those 35 years or whatever it is for general treatments. Custom orthotics, I've probably given him up to 10 pair up until 2011. At one point he was in an AFO, not supplied by me. I put him into a range of, over the years, rocker footwear, which has been extremely effective for him. And post-surgically, when he first had to weight bear after virtually 5 months lying flat on his back in hospital with that hip infection episode, I had to mail him out at hospital a stable rocker effects, which was the slide, the FitFlop slide, because this was a man who could only walk in various manifestations of rocker footwear at that point. Now, I realised he's been buying cramp stock from us since 2014, now known as Cramp Solve, and we covered that previously in an episode. It's the magnesium and arnica oral spray that you spray in under the tongue, both a preventative and also a treating the cramp when you've got it. And he's had far fewer cramps overall since we broke that cycle years ago. Now, I got my laser in 2016, and I've treated Pete with laser at various times when episodes of pain occur, such as been happening here. And that segment we covered where we alluded to those severe nocturnal cramps, 5 individual episodes every single night, 7 nights a week. I think that was about in 2017. So look, I've checked before with rock tape, and we'll just go a few minutes over just to finish up on this little segment here, because you know, there are a lot of our patients that have got these problems, but you don't necessarily know. You've got to really start asking the questions or checking on how they're sleeping. So there is no evidence to show this works for cramps, but you've only got to ask people like Pete and the 86-year-old that we talked about there. She was stoked, 95% improvement, and we now understand the implications of getting inadequate levels of sleep. So they think, and we've covered this briefly before, that maybe the pain receptors, which are your nociceptors, are maybe unloaded. Certainly your lymph vessels are allowed to, well, they're not being compressed as much, they think, is how this works. And they think, therefore, that if the muscles not so inflamed too, as a result of this change around your lymph reactions and your pain receptors and so on, that, you know, the muscle isn't going to be as inflamed. certainly, if I've emailed, and before we just cover this little bit, I emailed the physio at Rock Tape a few weeks ago. So that's the lovely Steve Stahl at Rock Tape in Perth. And what Steve has said is he thinks there's no particular evidence or research much because it's too difficult to control all the variables. You know, you can see Pete's overall scenario and the 86-year-old who's got musculoskeletal issues, but also chemotherapy-induced neuropathy. So, you know, there's a huge range of factors with all these patients. So you can see why it'd be hard to do studies. What Steve said was he believes that kinesiotape provides an alternative, and I'm reading from his email, sensory input to the brain, and that this then influences the output from the brain. And in the case of cramps, that perhaps this input of tape over the affected area reduces the resting tone of the underlying musculature, and that it might create a larger buffer whereby the lowered resting excitability of the muscles and the threshold of the onset of a cramp, or in other words, greater excitability, are changed. So it's speculation on his part, as he says, but he's saying that really the brain, we know it confers safety on our bodies. It works out what it wants to do for whatever part's suffering or being injured or whatever. And he thinks the reassuring sensation of the tape may reduce the protection tension that's held in the muscle. Now, and Rock Tape have been around for a long time now, and I've known Steve for, I think, about 10 years. If anyone's going to know the answer to this, he would. But look, if we look at our stats now, if it's over 35% of people over 50, and we've just covered a little bit about fatigue and dysfunction, you know, they think it may be a shortened muscle length, which is certainly the case in people like Peter, who doesn't have range of motion at all in the rear foot. They think maybe it affects sleep disturbances, but equally it causes sleep disturbances as quality of life is impaired. Now, this list needs to be updated because apart from all of these things that are mentioned here under being associated with, but, you know, certainly peripheral neuropathy and chemo-induced neuropathy. And I've talked before, and I think I've shown a little technique where I talked about when I keep some strips by my bedside, if I get a cramp from time to time every few months, I can be putting it on, and as I'm frictioning the tape and rubbing it to apply it, the cramp's already gone in the bottom 2 inches as I'm moving up more proximal, and I usually have it in my perineals. Okay, so look, we just had a technical glitch at the beginning because the Zoom booking, which had just not been automated, somebody had made a change at our end on the procedures and it seemed to drop that out. So apologies, we're a little late starting. Now, between now and next month, when it will be the 3rd Tuesday, the month after Easter, again, but we'll be back on non-daylight saving time, so 6:30 p.m. in Sydney and Melbourne time, an hour earlier. Before then, however, I'll be online again in about 2 weeks, which is a Monday. Heal with Laser are having another one of their events, and this is an international talk fest on the use of medical laser in podiatry. And I had a Zoom meeting early this morning, our time, with our colleague in Scotland, Kirsten Sinclair, who's going to be part of that. So she and I are the podiatry panel, and Dr. Catherine Norton will be facilitating the general discussion. So if you want to hear a bit more about the use in podiatry practice, but we're specifically talking about high-powered laser, which are the products or equipment that Heal with Laser distribute. And the smiling face there, Steve, I met in the UK via online. He's the distributor over there via Celtic SMR is the company in the UK. So I'm excited that we're going to be getting more and more global dialogue happening. I think that's wonderful. So it'd be nice to see some of you jump onto our Facebook group for Clinical Gems 2020. If you put that in, or you can just reach out to me, Bronwyn Cooper. It's got to be done through our personal names, not our business names. I can send you the link to join and admit you into the group, and we'll be posting some information there. So hearing from all of you in the next few weeks, and hopefully see some of you online if laser of interest to you. Otherwise, we'll see you online again in April. Thank you for being here tonight.